Neurology quiz number 26. What are the clinical features of spinal dural arteriovenous fistula? It is characterized by a direct connection between a radiculomedullary artery and vein without an intervening capillary bed, with resultant venous hypertension and infarction. The fistula is located in the intervertebral foramen. It constitutes 60 to 80% of spinal vascular malformations. It is most common in men in their 60s and usually located in the lower thoracic cord. Previous spinal surgery or trauma may contribute to its development. Symptoms are often asymmetric at presentation. These include radicular pain, numbness, tingling, and weakness of the legs. Sphincter disturbances occur later. At diagnosis, 70% of patients have a combination of upper motor neuron and lower motor neuron findings. Progression is usually gradual, but it can be stepwise, and 5% of patients present acutely. Worsening with exercise, leading to confusion with lumbar canal stenosis, as well as with Valsalva maneuver and corticosteroid administration, are other notable features. Misdiagnosis is common. Spinal MRI reveals T2 hyperintensities and T1 hypointensity extending over 3 to 7 vertebral levels, with dilated veins seen as flow voids on the ventral or dorsal aspects of the cord. Gadolinium enhancement can occur. Catheter angiography is the gold standard for diagnosis, but gadolinium-enhanced MRI can also be used. Treatment options include embolization of the fistula or surgery. A multidisciplinary approach can also be employed. This is a schematic representation of spinal dural arteriovenous fistula. Note the fistulous connection within the dural root sleeve and also the prominent draining vein on the surface of the cord. In this slide, first image is a sagittal T2 MR showing spinal cord hyperintensity and serpentine dilated perimedullary venous plexus as flow voids. The second image is a sagittal T1 MR with gadolinium enhancement showing tortuous and dilated perimedullary venous plexus. And the last image is a superselective angiography showing a feeding artery, spinal dural arteriovenous fistula, and a tortuous draining vein. This is from the paper by Zheng Y et al. From the Korean Journal of Radiology in 2015. What are the features of primary headache associated with sexual activity, previously called coital headache? This is a headache brought on by sexual activity, usually starting as a dull bilateral ache as sexual excitement increases and suddenly becoming intense at orgasm. To meet diagnostic criteria, there must be at least 2 attacks brought on by and occurring only during sexual activity that last from 1 minute to 24 hours with severe intensity and or up to 72 hours with mild intensity. Pain is initially dull but later typically becomes pulsating and throbbing. It is rare with a prevalence of about 1%. It is usually seen in adults but can occur in adolescents and is more common in males. 30 to 40% of patients can have coexisting migraine or primary exertional headache. In many cases, remission may occur after several months, but some patients have a chronic course or experience recurrences. Important differential diagnoses, especially for the first attack, include subarachnoid hemorrhage, intracerebral hemorrhage, RCVS, venous sinus thrombosis, and arterial dissection. Workup is essential to exclude these causes. Pathophysiology is unknown. In one study, patients were found to have venous stenosis on MRV, suggesting that abnormalities in venous blood flow may be important. Other hemodynamic factors such as increased cerebral blood flow may also contribute. Prophylactic treatment with indomethacin or sumatriptan given 30 minutes prior to sexual activity can be effective in most patients. Beta blockers can be used for long-term prevention if attacks are frequent. Patient education and reassurance, emphasizing the benign and self-limiting natural history, is also important.